Good evening, everyone. Hopefully we've all managed to make it in. Welcome to this DDU webinar on good record keeping. My name's Simon Kidd. I'm the head of the DDU and I'm joined by Alison Large, one of our dento-legal advisors. So without further ado, I'm going to hand over to Alison now to do the first section of the webinar.
Hello and welcome everyone to this evening's presentation on record keeping. I was just going to tell you a little bit about myself in that I qualified in 1999 and I have worked in various different dental practices before joining the DDU. So from working in practice to my role in the DDU, I think I've got some fair experience of looking at different records and puts me in a good position to discuss with you tonight the importance of good record keeping. And that's one of the aims of today's presentation, alongside covering the standards set by the profession. We also aim to look at the purpose of records and what the expectations are. And we will be covering ethical and legal requirements. So by the end of the presentation, you should have a greater understanding as to why good records are needed, as well as the elements that constitute an ideal record. For the purpose of your CPD, this webinar covers two of the GDC's developmental outcomes, and that's outcome A and D. There's a particular focus on communication, ethical and legal issues, and professional behaviour. So to start off with, we wanted to know a little bit about the record keeping methods that you're using at the moment. So you should be able to vote on the poll, and we would like to know what method of record keeping you're currently using. A is handwritten notes, B is computerized records with no templates, C, computerized records with templates, D, computerized with AI templates, and E is computerized with AI audio transcription. So if you can vote now, that would be really good and really interesting to find out what everybody's doing at the moment. So I think we've got quite a lot of results in, so I will have a look and see what those are. So there we go. That's very interesting, and I think along the lines of probably what we'd expect and what we see in our day-to-day role. Some of you use handwritten records. That's 6.8%, and a similar amount are using computerized records with no templates. But the highest scoring we're getting there is computerized records with templates. So whatever method that you're using to record your records, it's important to remember that it's not the amount of records that you're recording that is the important thing. It's very much the quality of the entries that you're recording that are key. But we do appreciate that producing good records can sometimes feel a really big ask, especially when you take into account all the other factors that you're considering when you're treating patients. So very much using templates can be a very effective way of trying to reduce that burden of the length of time as well that it's taking to complete writing up your patient's records for any given appointment. So hopefully within this presentation, we cover some considerations that may help to make that task of record keeping more manageable. So in this evening's presentation, we're going to cover, between Simon and I, the purpose of records, what the GDC expects, GDPR, and the ideal record. And I'm going to start, first of all, to cover the topic of the purpose of records. So it's really important to remember that the primary purpose, the main reason that you're making those records is for clinical reasons. The records should be an accurate picture of the care and treatment that you provide to a patient at any given consultation. So this should include your findings, diagnosis, discussion, and the treatment that you're planning to provide. Certainly, I have to say that I've seen records where members have made very detailed records relating to various aspects of their appointment with the patient. However, sometimes the actual treatment provided isn't entirely clear, or it's sort of buried within lots of other detail that's provided. So really sensible not to overlook the key entry detailing what you've actually done at that appointment. It can also be a helpful way to structure your thoughts and decisions. An example of this may be in circumstances where you've assessed a patient's capacity and are then acting in a patient's best interest. Detailing your thoughts of how you came to the decisions that you made and actually recording them within the clinical records can be really useful, particularly if later on that decision was in any way called into question. Having an illustration in your records of your thought process can be really useful to look back on, and will be able to give an account of what steps you took to come to the ultimate decision that you made. The records are also a communication tool, and that is between other dentists, other dental professionals, and that's both in and outside of the practice. Certainly in the current working situations, we're seeing more and more interactions with dental care professionals, and it's really important that the records are clear and accurate. I've seen clinical records and referrals where those details weren't particularly clear, and unfortunately in some of those cases have led to the wrong tooth being treated or the wrong tooth being extracted. So it's really, really key to make sure that that information is clear and you're communicating well with others involved in treating your patient. Also, you're making records for your own reference. They can be a really useful aid memoir so that you can look back at previous appointments. It may be helpful to jog your memory about where you are in the treatment plan, what had been discussed with the patient previously, when the last radiographs were taken, for example. So these are all clinical parts of the clinical reasons why you're keeping records. And the secondary reason is for dento-legal purposes. So as a dento-legal advisor, speaking to you about record keeping, you may be a little bit surprised that I'm recommending that this is the secondary purpose of records. And certainly if you are focusing on making records for clinical purposes, normally then they will act as being good evidence when they're needed to be looked at for dento-legal purposes. In our experience, if they're written for dento-legal purposes and you start focusing very much on being defensive and writing the records in a certain way, then sometimes you can come a little bit unstuck by that. But there are times when the records may be looked at, and they may be put under a lot more scrutiny than when you yourself are looking back on the records for the clinical purposes. And one of the reasons that records may be looked at are if a patient is pursuing a clinical negligence claim, and records may be looked at and may be looked at by experts to try and establish the standard of care that you provided. Another reason that records may be looked at are from a terms of service perspective, and this is all about probity. So if you're working in the NHS and you've completed treatment that you've claimed for, then the records may be scrutinised. They may be looked at to make sure that that claim is justified, appropriate, and in accordance with the NHS regulations. We also see situations where records may be looked at by a solicitor, for example, in a situation where the patient's making a claim against another dentist, and you might have subsequently treated that patient, and your records need to be looked at by the solicitor. There are also instances where insurance companies, for road traffic accidents or in situations when a patient may be have been assaulted, that these third parties may be needing to see the records. There's also situations where the records may need to be disclosed to third parties, and these third parties could be social workers or police. If you're ever in a situation where you're being asked to make a disclosure of the records, please come to your defence organisation first, and we can chat through the scenario that you're dealing with and make sure that you are protecting patient confidentiality and making sensible decisions in terms of making disclosures. As I mentioned, another reason you might carry out have records is for your own clinical audits. You might review your own records, or someone at the practice may be reviewing your records. Occasionally, you may find yourself in circumstances where someone else is looking at the records, and this can happen in the early stages of a GDC investigation. And a clinical advisor will review records and make comments on the information that's available. Another scenario where that might happen is where a negligence claim has been made. There can also be situations where the NHS may be looking at clinical records to try and assess clinical performance. So it's the entries within the clinical records that any of those decisions are going to be made on. And when this approach is taken, there may be shortcomings identified in the records, and that may be considered to be a reflection of the actual care that's been provided to the patient. So this is the example of a clinical advice report, and the advisor that's produced this report has been quite critical. At point one, they're saying the whole set of the handwritten notes was close to unreadable, which is a significant failing. And we've talked about all the reasons why you're recording records. If other people can't read them, they're really of very little help at all. This advice report goes on to say at point two, examinations were brief and lacking in explanation of discovered issues. that would be in the GDC case, appears to have failed to diagnose active caries in a number of teeth, rendering the prognosis poorer. So the conclusion that has been made is that the lack of detail has prevented a more in-depth description of the case and detailed comments on the informant's issues. So when it's a GDC investigation, the informant is the person that's complained to the GDC. So the lack of information within the records has made that it's very difficult for the advisor to see what was actually provided to the patient. And at an early stage in a GDC case, this may mean that things are passed forwards because there's little explanation within the records about the treatment actually carried out. So considering the importance of records, looking at this slide, we've got, can I afford the time? Can I afford not to have the time? And really, I don't think you can afford not to have the time to make records for some of the reasons that I've mentioned earlier. And it sounds like that the majority of the people on this webinar today are using templates to help them make records effectively within any limited time that you may have. What I would say, it's absolutely not the case that if you haven't recorded doing something in the records, that it will be assumed that it didn't happen. However, if you do have a record of it happening during the appointment, that may be immensely useful in circumstances where allegations are being made about the standard of care that you've provided. So yes, it does take time to make good records and cover all the aspects that I've mentioned, but certainly it's normally well worth taking the time when you have the patient with you in the surgery. And I've personally been in a situation where I've had a complaint about my own clinical care, and there was an allegation about not treating caries, not identifying treating caries. And this happened many, many years later after I had left the practice. And I wouldn't be able to recall the approach that I had taken at the time. And unfortunately, which wasn't very helpful, the practice was no longer able to locate the digital bite wings that have been taken. Thankfully, though, I had made a quite detailed entry in my own clinical notes reporting on the radiographs. So even though the radiographs weren't there and weren't visible to be assessed, they could rely on my entry within the clinical records about what my findings were at the time. So I think this really crucial in illustrating how important the records can be later on down the line. And in the complaint that I was dealing with, it was really helpful to be reminded of my findings and the advice and the approach that I took at the time. So really this brings me on to the next topic that I want to discuss, which is the GDC's expectations. So what the GDC expects of you is set out within this document, Standards for the Dental Team, which was published in 2013. And it is Principle 4 that deals with the maintaining and protecting of patients' information. And at 4.1, it sets out that you must make and keep contemporaneous and complete and accurate patient records. Now, within standards for the dental team, the GDC gives definitions of when it uses the word must, and when it uses the word must, this is a duty that is absolutely compulsory. The GDC goes on to say that at 4.1.1, you must, and again, the must is a compulsory, make and keep complete and accurate patient records, including up-to-date medical history each time that you see and treat patients. Radiographs, consent forms, photographs, models, audio and visual recordings of consultations, laboratory prescriptions, statements of conformity and referral letters all form part of the clinical records. So it's it may seem obvious that all these parts form part of the clinical records, but sometimes they're stored in different areas, in different places. And it's really important to remember that if you're asked to share records, that you need to be looking at sharing the complete records. It's also important to note, I think, that audio and visual recordings form part of the patient's clinical records, and that means that they need to be kept in accordance with the normal timeframes, and patients have right of access to those audio and visual recordings as well, in the same way that they have a right of access to the rest of their records. So you should record as much detail as possible about the discussions you have with patients, including evidence that valid consent has been obtained. You should also include details of particular patient treatment needs where appropriate. So it's important that you're detailing the actual discussions that you have with the patient in the process of obtaining consent. And we have further CPD on consent available at the DDU. It's really key to be aware that the consent isn't an one-off process. It's an ongoing process, a two-way discussion with the patient, and you need to be satisfying yourself that the patient has fully understood all the information that you've provided them with and the alternative options as well. And it's ordinarily the entry within the clinical record that's relied upon if consent is called into question. Written consent forms can be helpful additional information, but the GDC is setting out that you need to make a record of those discussions in your clinical notes. And you must ensure that all documentation that records your work, including records, is clear, legible, accurate, and can be readily understood by others. That goes back to that critical report before, where it was entirely unreadable handwriting. You must also record the name or initial of the treating clinician. The GDC says at 4.1.5, if you need to make any amendments to patients' records, you must make sure that the changes are clearly marked up and dated. So we talk about contemporaneous records. They're records made at closer to the time of when the treatment's provided or the discussion takes place as possible. If you do need to make any records that are outside of that time frame, it is essential that you are recording when that has been added, and normally really helpful to make it clear that it's an addition made at a different time. Some software systems do unfortunately allow changes to be made, and upon reviewing the records, that might not be immediately obvious that a change has happened to the records. However, in the back of the computer system, there is normally a record that the changes have been made. And certainly I've had cases at the GDC where there's been an interrogation, an IT interrogation into the software system, and it is all marked up in the system where the time and date of any changes that have been made. So really key to make sure that if you are making additions to the records, that you make it absolutely obvious in the entries that you're making, and don't try to pass off any changes as having been there at the time the records were made. It also says at 4.1.6, if you refer a patient to another dental professional or other health professional, you must make an accurate record of this referral in the patient's notes and include a written prescription when necessary. This is something that can get overlooked, I think, using digital referrals. The GDC is saying that you must make sure that there is a record of that referral, and if you're asking one of your colleagues to undertake some treatment and passing the patient on to someone else, really essential that that prescription is also within the records. And this is a question that I think we come across quite often, which says that you must, and bearing in mind that the GDC's must is something that's compulsory, you must give patients a written treatment plan or plans before their treatment starts, and you should retain a copy in their notes. So this means whenever you're providing patients with treatment, they need to be receiving that written treatment plan. It's also often required in the NHS, but the GDC is setting out that they expect that all patients should be receiving that written treatment plan. It goes on to use the word should, which should be used in the majority of situations. So the good practice is to be asking the patient to sign that treatment plan and you keeping a copy of that treatment plan within the clinical notes. And 2.3.8 goes on to say about if anything changes in that treatment plan, and certainly more involved, more lengthy treatment plans often mean that changes can and do happen, and it's essential that you're keeping the patient up to date with those changes and making sure that they are given a revised cost estimate if those changes mean that there are different fees involved. And the GDC is saying that you must inform the patient of these changes immediately. In terms of what should go into the treatment plan, the proposed treatment, a realistic indication of the cost, and importantly, whether the treatment's being provided under the NHS or an equivalent health service or privately. And if it's mixed treatment, then it should be clear on that treatment plan which elements are under the NHS and which elements are being undertaken privately. And in our experience, complaints can sometimes arise when patients are unsure as to whether they are receiving treatment privately, and certainly the GDC takes quite a dim view if they consider that patients may have been some way misled. So that brings me to the end of my section. So I'm going to hand over to Simon now, who is going to cover GDPR. Simon.
Thanks, Alison. So another key consideration when discussing good record keeping is the fact that any information that you hold about a patient is confidential. And even the very fact that a patient is confidential information. The principles of data protection, including confidentiality and the making, storing, disclosure, or deletion of records, is all set out in the GDPR and the Data Protection Act 2018. And it sets out 6 key principles that apply to all living patients' records. These specify that personal data must be used fairly, lawfully, and transparently. So think about having clear data protection and confidentiality policies in place at the practice, and if you're an associate or a DCP working in a practice, being aware of those. They must be used for specified and explicit purposes, and these purposes should be set out in your practice data privacy notice, which should be readily available to patients either on your website or at the practice. They must be used in a way that's adequate, relevant, and limited to only what is necessary. So in that case, you'd be thinking about the differences between using patient information to legitimately manage their care and perhaps misusing it for marketing cosmetic treatments without their consent. It must be kept accurate and up to date. So that's things like keeping contact information up to date, medical histories updated, and it must not be kept for any longer than is necessary. So that's where your data retention policies and protocols come into play. And lastly, it must be handled in a way that ensures appropriate security, meaning protected against unlawful or unauthorized processing, access, loss, destruction, or damage. Think about logins and passwords and backup systems, and if you're using paper records, how you would securely look after those, protect them from fire, and so on. Under the GDPR, you must give patients the lawful basis for processing the data. And as I mentioned, this is usually set out in a practice data privacy notice, again on the website, usually, but it can be available on site in print if need be. I'd strongly advise that if you do have a practice privacy notice, which would set out all the reasons you would normally use patient data, which would include things like managing their appointments, managing their care, making appropriate referrals, they're usually listed in a privacy notice. But I would also strongly advise, if you haven't already, that you include within this some scope to share information with your indemnity provider and legal advisors for the purposes of responding to complaints and claims. Otherwise, if you do find yourself in the unfortunate position of having to respond to a complaint, especially if you've left a previous practice, it's quite difficult to get hold of the records without having to then seek patients' express consent to share that information in the first place. So if that's built into your privacy notices, that's a really helpful way to avoid that extra bit of admin and a bit of delay in responding to patients. As I also mentioned, one of the principles of data protection is about data retention and storage. The key thing for practices to do here is to ensure that you have a clear data retention policy and schedule. There will be some competing tensions between the reasons to hang on to patient information, for example, your dento-legal defense, and the data protection principle we mentioned earlier about not retaining information for any longer than is necessary. It's ultimately for the data controller at the practice who's legally responsible to take the advice of their data protection officer and establish what the retention schedule should be. And that should be based on various factors, which includes guidance from sources like NHS England, who do set requirements of how long you hang on to records for your NHS patients. And in practice, most NHS providers, or most private providers, would just mimic what the NHS does to make things simple. But again, it will depend on whether you've got paper records, whether you've got digital records, whether you can archive them, whether your patient's still alive, whether your patients are still returning to the practice. So there are various situations where you might spell out in your retention policy how you will retain the records, when you will review whether to archive them or delete them. Just a note on computerized records, and I know that the vast majority of you in that first poll reported that you're using computerized records at this stage. It is vital that all the safeguards are in place to protect patient data, and practices should ideally take advice from the practice management system supplier and be aware of their responsibilities under GDPR. There should be some very clear confidentiality clauses in staff contracts, and that's for both clinicians and your employed staff that aren't registrants. Dental professionals and other support staff should also be aware of those data protection policies and make sure they have read them, and ideally as a practice, you'd want to make sure the staff have read and signed those and do so regularly to make sure they're up to date with any changes. A common question we are asked is about letting other members of staff use your login to write notes on your behalf. Generally, I would advise against this. The reason being, if it's ever called into question who actually wrote a record entry, it's quite difficult to say, well, my assistant wrote the notes in their login and then a different dentist didn't have a login and my trainee had a different login. It makes it very difficult for a third-party investigator to attribute who did what in that scenario, which can get people into a bit of hot water. It's much safer for every user of the system, every data processor, as they would be known, to have their individual login details and not share those details with other people, so that you can be quite sure that the record entry was inputted by you and that no one else can edit those records in your name. Again, it's a key principle of data protection that computer records are also appropriately backed up. Now, whether you do that on site through plug-in disks that you take away off site, store securely somewhere, whether that's through cloud backup systems, it doesn't really matter. As long as you've got a setup in place to back up data, then you will meet that key principle within the Data Protection Act. Moving on to what is the ideal record? Well, it should be all of these things. And already said from the GDC standards, they need to be contemporaneous and legible. And I would say they need to be clear, which is legible and intelligible. And I'll show you what I mean by that in a couple of slides' time. They also need to be concise. And again, Alison's already touched on the issue we have now where records are far too detailed and actually causes problems. They need to be accurate and they need to be complete. But before I go on to talk about what contemporaneous actually means, because I can see that there's already been quite a few questions about contemporaneous, I'd be interested to know what the attendees think about what contemporaneous actually means and when they think the cutoff for writing up notes after seeing a patient should be. So if you could complete this little poll for me. If you think the cutoff should be immediately after the appointment, click A. If you think the cutoff should be at the end of a session, click B. If you think it should be at the end of the working day, click C. Or if you think it should be within 24 hours of the appointment, click D. So what do you think makes something, in inverted commas, contemporaneous? So interestingly, 43.9% said immediately after the appointment, 22.8% end of a session, 15.8% end of the day, and 17.5% within 24 hours. Well, contemporaneous quite literally means at the time, but in practical terms, this means during the appointment or immediately after. I'm often asked if it's okay to leave it to the end of the day, and my response is always to think about how you might answer questions from a barrister at the GDC or in court defending a negligence claim. Say a patient was the first patient of 30 patients in a day, and you've carried out the same procedure on that patient that you've carried out 10 times more during that day. Would you, under interrogation from a barrister, be able to say confidently under oath that you remember the full detail of the discussions at 9 a.m. all the way along to 6:30 p.m. when you made that record entry without conflating it with other patients? I know I wouldn't be able to do that. That might be age-related, but it's quite difficult to convince a barrister of that fact, and it does potentially cast a little bit of doubt over the accuracy of the records if you leave it so long. In our experience, notes are most defensible if they're written at the time, or at least are being finalized by no later than the end of the session, at a push at the end of the day. Now, ideally, most of the notes are actually getting entered at the time, but if you're just finalizing them at the end of a session or the end of a day, that's slightly different, because the actual detail and the important points are probably already in there. And if you're going back just to tidy them up and just to add in any final comments at the end of the day, that's fine. But I would suggest that at an absolute push, the end of the session is when you write your notes, because anything longer could cast doubt over whether you actually have an accurate recollection of what happened at the time. Retrospective entries, I know Alison touched on this in terms of the GDC standards. If you are going to put a retrospective entry into the notes, and this is a note after the fact, as in after the notes have already been locked at the end of the day, if you're going to actually go back a week later because you realize you haven't put your radiograph report in, it's really important that that entry is flagged as a retrospective entry written at the time on the day that you write it, rather than going back and manually editing a note from a week ago. It's simpler just to say in your records, this is a retrospective entry for a radiograph report that I forgot to do the last time. I didn't do the last time. I'm writing it now because I wanted to complete my notes. That is still valuable evidence that you've actually, got something in the notes, and third-party investigators are quite understanding generally about that. But obviously, it's much better if the notes are made contemporaneously. It is potentially possible for a patient to come back and say, my notes have been tampered with. So if they say that, it's quite possible for the GDC to instruct an IT expert to go through the audit trail of record entries in the background of your software system and establish whether or not a record has been tampered with. And if that is the case, you've gone back and dishonestly amended your records, the GDC would take a very dim view of that. You shouldn't really ever be tempted to cover up errors. It's much easier defending an error than defending someone who's been deliberately dishonest and misleading. So we talked about legible. Those of you that are using computerized records, your records will always be legible. For those of you that use handwritten records of work in a dental hospital where they still use these familiar looking yellow cards, it's really difficult to justify that as legible. That is a real record. I can work out as an experienced dentist about half of what's being said there and what's been done, but it's by no means easy. In cases like this, I routinely have to go back to the member and ask what happened, what did you do, what's the plan, what's an actual completed treatment, do you recall the conversations you had with the patient at the time? So again, it needs to be actually readable. Intelligible, slightly different. Intelligible is about whether the information that you provided is actually able to be made sense of. This is legible, I can actually read the words, but I cannot for the life of me understand what's happened, what's being planned, who did it, when they did it, what's been done, just because the information is just incomprehensible. So again, when you're writing your records, they should appear almost like a story from start to finish, so that the person who comes along next can understand what your thinking was and why you did what you were going to do. Concise, and again, Alison's already touched on this, but your notes need to be concise and relevant. There's a fine balance to be struck when thinking about the information to include in your records, and the important thing to remember is why you're writing those notes in the first place. And I'm labouring it again because the primary focus for your records is to manage patient care safely and effectively. Too much information can actually be counterproductive and potentially unsafe because you risk losing the key details in pages and screeds of unnecessarily detailed notes. There is, however, a basic minimum, which I'll go into in a moment, because I know a lot of you have asked questions about that. But all too often, we are now seeing records for a simple filling procedure that could fill 3 sides of A4. And I can assure you that neither the GDC nor a judge expects you to detail the burr that you used, nor give a full detailed description of the etiology of periodontal disease every time you do a scaling. In this age of auto notes and transcription, notes are really getting quite unhelpfully and unnecessarily detailed, and we are long overdue some updated guidance on perhaps using SOPs as a way to minimize this. So if you do the same thing the same way every time, is it possible to have a standard operating procedure to record how you would do that? And the GDC are actively looking at this as a way to sort of cut through this problem. So on the point of the basic requirements, so the GDC standards, they set out the requirement of dental professionals to make good records. So you're required to make good records, but they don't actually say what the standard of record keeping should be. They instead rely on dental professionals to follow guidance from a responsible body of opinion. And for record keeping, in general terms, the standard you'd be held to is this guidance on the screen here. It's the CG Dent guidance named Clinical Examination and Record Keeping. It used to be called the FGDP, which is why it still says that there, but it's now CG Dent. This information is available online. It's free to access as a PDF download. You will need to make a login to do that, but you can get it for free. And I suggest that it's something that you have linked on your desktop or download a copy to have to hand so that you have quick access to the record keeping standards that you'd be held to. It helpfully takes an ABC approach. So to answer the big question, what is the absolute bare minimum you have to put in the notes? It is basic, as in the B. It does set out aspirational standards, that's gold standards, which is what you can include in the records, but the GDC and others would only hold you to the basic standard of record keeping that is in this book. And it does set out lots of checklists of the things that you must include to get to the basic standard. And also the C stands for conditional, and conditional is obviously just records that are specific to a particular situation. So it does go into a lot of detail about the records you should make in trauma and pediatric assessment and toothache appointments and so on. And conditional records are all set out in there. So I know a lot of you have asked for templates. It's not really the DDU's role to set the standards because the standards already exist. So our advice is always, rather than us provide you with a template that would need to be changed every time there's a bit of an update, look to the guidance from a responsible body of opinion and make sure that templates that you do use are fit for purpose with your practice systems, but also in keeping with relevant guidance. So this is the profession-wide standard. This applies to dentists, it applies to DCPs, private or NHS. But for NHS registrants, there's an additional layer because the NHS also set their own standards and they also have their own checklist. It broadly aligns with the CG Dent guidance, but they have a few extras in there that they expect you to do. So again, when you're thinking about setting up templates and making sure that your record keeping's up to scratch, if you're an NHS provider in England, those standards are there. If you're elsewhere, different countries in the four nations will have different approaches. For example, in Scotland, where I work, the narratives in the SDR set what should be included in an examination in terms of the actual things that you're assessing. And the way you evidence that is by documenting them in your records, which slightly adds to what is in the basic level of clinical examination and record keeping guidance that we see before us here. So the things that you need to include, I mean, the bottom line is, there's a list here, but the bottom line is everything that's set out in the CG Dent guidance at the basic level and the conditional level, depending on what you're doing. I'm not going to go for each and every check on the list because there are dozens of them. But if you are wanting to do a little bit of an audit of your own templates to make sure they're fit for purpose, my advice is, if you're an NHS practitioner, get the NHS checklist out and the CG Dent checklist out and just make sure that each of your templates aligns with that guidance. And that's a little task you can do quite quickly, to be honest, because it's just amending one template rather than every record that you do. Lastly, and unfortunately, there's also a third layer to that sometimes, depends on where you work, but quite a lot of corporate providers now will insist that there's a certain standard of record keeping that's maintained by practitioners and clinicians who work within their corporate structure. So if there's an additional layer of standard applied that requires you to work a bit closer to that aspirational level because of your employment contract, for example, if your associate agreement says you must follow practice policies and procedures, and one of those policies is you must keep record keeping up to this standard, then you need to make sure that if you are using bespoke templates, that it also ticks that box as well. One thing that's consistently missing from the records that I review on cases is a formal diagnosis. It is a requirement that you include a diagnosis, but on a practical note, it is just common sense to actually document the diagnosis that you reached, because this is the justification for the treatment that you're going to provide. And again, being able to sort of read that narrative in the records as to why you did what you did. You've got your assessment, you've got your diagnosis, you've got your treatment plan and options, risks and benefits, and then the finalized treatment plan and what you're going to do next. Again, that's sort of the basic structure of a record, and that's a really easy story to follow for anyone who comes along next. The treatment visit, again, you do not need to include masses of detail here. You need to record what treatment actually happened, but you do not need to describe the color of the wedge that was inserted in the type of matrix band. The fact that you've done a filling and the people who are going to be reviewing your notes are going to be clinicians who know that you use the matrix band and wedges is enough. You don't need to detail that in any great amount. What you do need to record is any mishaps and complications. So for example, if you find that the caries that you remove is a bit closer to the pulp than you first anticipated, then you would document the fact that it was a deeper filling than first planned, and you would document the discussion you had with the patient about what that actually means for them in real life. You might get some sensitivity, toothache, that might lead to X, Y, and Z. It does also say that you need to date and sign them, but again, if you're using a computerized system, that just happens automatically, provided that you're using your own login. Just again, I really must labor this point. I know we've mentioned it twice already, but really do not try to hide errors. One of the things that one of the sanctions that you get to the GDC, the most severe, is always going to be something like a suspension or an erasure. It's quite hard to get suspended or erased by the GDC, but one very easy way to do it is to lie. And if you're found to be dishonest, that speaks to your character rather than making errors. So it's much better just to make sure that the records are honest, and if you haven't completed the records, try to remedy that with a retrospective note. Just be careful about personal, humorous, subjective comments, because patients can request the records. If you're writing a record, it's really important that you write only what you'd be happy for the patient or indeed the GDC to actually read, because if you write something like this and it's looked at by the GDC, again, there's a sanction potentially coming your way. Alison's already mentioned written treatment plans and fee estimates. Again, it is a requirement that you provide them, even for exempt patients. The only time that you wouldn't do it is if the patient's coming in for an examination and there's no treatment advised. But if there's a fee associated with that examination, they should be aware of that before they come to the appointment, so that's not a surprise to them when they get the bill. It's also a requirement of NHS regulations that you give them, for example, in England, the FB17 with the treatment plan detailed on it. It's also helpful in defending claims because you can see what the plan was. It's also helpful in recovering debts. So if your patients don't pay their bills and you want to take them to small claims court, you've got to really produce evidence that the patient actually knew what the bill was going to be and what you have invoiced them. And without that evidence, it's quite difficult to actually claim the money back. Again, templates. Alison's already covered this in some detail, but again, excellent aide-memoire. But it's just really important that those templates aren't pre-populated. Pre-populated templates lead to a lot of risk, because if you copy and paste in templates, or if you use a pre-populated template and forget to amend it to fit the particular circumstances of that consultation or that treatment visit, someone looks at it later and says, well, that didn't happen. That can cast doubt over the entire record, and it makes it quite difficult for us to defend your actions in that regard. So it's much safer to use prompt-based templates where you list all the things that you want to record and then have to manually complete or use a drop-down to select the correct option as and when you complete the record and finalize it. Just a little bit about AI, because I saw that a small percentage of you are using AI as a record-keeping tool. In terms of AI, the big thing is that the records are, I suppose, I'll go back to there's two types of AI I've come across. There's the prompt-driven ones, where you essentially click through a series of prompts and it sort of generates quite a detailed record of the appointment. The problem with those ones is, again, it's much like the copy and paste auto notes. It will guess what you probably did rather than actually record what you actually did do. And again, it casts some doubt. The next generation, the ambient scribes, these are microphones on your lapel or a little box in the corner that listen to the consultation. They transcribe the entire consultation, then use AI to summarize the consultation into a brief record, which you can train to put into a template format that you're happy with, that aligns with current guidance. That's all very clever and very useful. It's much more accurate because it is actually a true representation of what happened at the time. And the important thing is when you use that you check it over the summary, because it can hallucinate, it can put in errors, it can mishear what you've said. If you use double negatives, it can misinterpret what the actual intention behind that was when it does its AI summary. So you need to make sure that the final entry is as you would have it, and the responsibility falls to the clinician. You cannot blame AI for an inaccurate record entry because you've got to check it. There is the issue of governance. Individual associates shouldn't be using AI without having first discussed it with the practice of the service they work for, because the practice will have policies and procedures to put in place in terms of governance before AI can be adopted. If you are using it already and haven't run it by your practice, I would suggest that you stop using it until the practice has a chance to take advice and sort that out. And one of the big things is, while this is still in its infancy, it's really important that you seek patients' consent to actually record them. Now, I appreciate that a lot of the recordings used by AI transcription systems don't actually get kept. They just transcribe it into a document, and that document is disposed of after the summary has been accepted. But the patient will still have a perception that they're being recorded. So it's important to get the consent before you use that software, and respect their wishes if they say, no, I'd prefer not to. So in summary, as Alison and I both hopefully laboured enough, no notes is a difficult defence. Too many notes is unhelpful and potentially unsafe. There's a fine balance to be struck, and the guidance comes from that really helpful CG Dent book. Again, the thing to take away from this is go and have a read of that and make sure that your templates align with that. But also, if you're an NHS practitioner, if you work for a corporate that has standards in place, make sure that you're in keeping with them as well. There's loads of resources on the DDU website about how to sort of manage records appropriately. And if in doubt, we have the advice line. Just call us up anytime, and we'll be very happy to answer your questions. Before I just go into the final housekeeping, I can see there's quite a lot of questions. Alison, have you got any questions you want to chuck at me? I'll do my best.
Oh, yes. So, well, I think you covered quite a lot of the questions that were being asked earlier on about contemporaneous records, and also a little bit of requests for templates. But one of the interesting questions that we had, that I think we probably get asked quite frequently, is about who the records actually belong to. Do they belong to the practice? Do they belong to the patient? Or do they belong to the dentist? And I think we sometimes get questions about this, particularly in terms of things like patient photographs, for example.
Indeed. Well, I mean, the short answer is they belong to the data controller, who has overarching responsibility for the data management of the practice, i.e. the person who could legitimately pick the server up out the wall and take it away with them, which wouldn't necessarily be an associate that's also a data controller. Associates might be data controllers in their own right because they have control over images on their personal devices, for example, but it would be the person who has overarching ownership of the practice systems and is registered as a data controller. So they own the records. The records are for the dental professionals to use. It's for the safe and effective management of patients. So that's what they're for, and who has access to them as processors. So that's not ownership, but they should have access to them for the safe and effective management of patients. They're not for patients, but patients have access to them under the Data Protection Act. So they can make a subject access request to request any part of the records, and any confidential information or patient information you hold about them is disclosable under an SAR if the patient does request them, or someone who has legitimate responsibility for that patient can request them on their behalf. Any request, as Alison said, should be immediately a phone call to your dental defence organisation to check that it's actually appropriate to disclose the records in the first place. But generally speaking, the ownership is the data controller, but the data controller specifically who owns the actual practice systems.
Great. And then there have been several questions, and thank you everyone for engaging and providing these questions. We've had quite a lot of questions about the time pressures that everybody is under in terms of creating those records. But one question what we've had is there any difference if recording notes in an out-of-hours setting where there's time is limited and treatment is urgent and for pain relief?
The short answer, no. The GDC standards are the GDC standards, and as Alison went through quite a few of those apply no matter where you carry out your practice. So there's an expectation that you must make and keep detailed contemporaneous records, and the standard that you're held to for those records is, as I've explained, the CG Dent standard of record keeping. However, there are conditional levels of record keeping within that guidance. So for urgent care appointments, you don't need to write a full exam note like you would for a new patient exam. And again, the level of detail is conditional on the circumstances, and the book does go into quite a bit of detail about that.
Great, thanks, Simon. Well, I think we've got quite a lot of other questions, but I'm aware that we are have covered been speaking for an hour already, so I think you're going to let everyone know what we were going to do about answering any questions that we haven't got round to answering during this webinar anyway.
Indeed, we have taken note of all the questions that have been asked and haven't already been answered, either throughout the presentation or in this Q&A. We will, in the next couple of weeks, upload some FAQs alongside the on-demand version of this webinar. So you should be able to access that in a couple of weeks, and I'll try my best to answer as many questions as I can through that mechanism. Thank you very much, everyone, for coming along.